I'm going to be speaking to you about compartment syndrome, but probably not from head to toe because time will not permit. I'd like to start by saying that many times we face diagnostic dilemmas, and I've just listed some of them. When you fail to diagnose what is threatening to life, limb, and if the limb is threatened, then sometimes to the wallet, clinical findings suggest the need to test are extremely common. The clinical findings excluding the disease are not reliable. The actual disease may be uncommon. The test that is to be performed to diagnose the illness is onerous, it's expensive, or it is risky to the patient. The ability of the test to rule out disease may be limited. There may be a large number of negative studies and a large number of false positives. And then, there are these situations where we often make mistakes of this kind: pulmonary embolism, deep vein thrombosis, aortic dissection, traumatic aortic rupture, ovarian torsion, and so on. And at the end, I put compartment syndrome because it's difficult to diagnose and difficult to treat and no easy test. I've put this slide up of a lady. Anybody wants to make a spot diagnosis? It's because of extravasation of a drug. Purple glove, phenytoin. So, you may well ask, compartment syndrome, why have they said head to toe? What is? Like Hansa Ben would ask in Khichdi, the movie. And then she could come up with the answer that it's a compartment which is crowded, packed to capacity. But that's not what I'm going to talk about. Compartment is a compartment, and a compartment syndrome occurs when there is raised pressure within a facial or a compartment space. This leads to decreased capillary perfusion and results in risk to tissue viability. So that's what a compartment syndrome is about. And then, of course, if you stretch your imagination, you could say that you have the acute limb compartment syndromes, because that's what is classically described. And the limb could be any limb. You could include the abdominal compartment syndrome as well, because it's called compartment syndrome. You could call raised ICP as the skull compartment syndrome. You could call pericardial tamponade as a pericardial compartment syndrome, and tension pneumothorax, and so on. So the list is, in that sense, endless. But what I've decided is to restrict myself to the limb compartment syndrome. I'm sorry for this slide. I did not realize that it's going to look so small. But the crux is that raised pressure occurs because of a variety of causes. Either external pressure because of a tight bandage, or it could be because of vascular insufficiency or bleeding within a limb. It could be because the limb was ischemic and then it got reperfused, so you get ischemia, reperfusion, edema. This raised pressure then leads to decreased capillary perfusion, and that follows an increased tissue pressure, which initially causes a venous obstruction, then an arteriolar insufficiency, and then it may lead to decreased capillary perfusion. And then finally, decreased tissue viability. So you would get muscle and nerve ischemia, which would give you the classical signs and symptoms. Then very severe inflammation, which leads to perpetuation of the cycle of edema, increased pressure, and cell death. And within about 6 hours, you may get a limb which is totally unviable. The causes include orthopedic fractures or the management of fractures. I've got one picture later on which I'll show you. Vascular iatrogenic causes, vascular puncture, especially in the anticoagulated patient, and intraarterial drug administration, extravasation, like I showed you, and maybe others. Soft tissue injuries like crush and burns, snake bite, these could lead to the compartment syndrome as well. And hypotension tends to worsen all these above causes. The orthopedic causes include tibial fractures. The range is, the incidence is up to 29% in some series, and it depends on the threshold for diagnosis. The anterior compartment is the most commonly involved, that is the shin. Then the forearm fractures, leading to a volar or flexor compartment syndrome. If there's a comminuted fracture, it increases the risk. Open fractures roughly halve the risk. The treatment of fractures especially increases the risk of having this compartment syndrome, and some of them have been put up here. I'm not an orthopedic surgeon, so I won't be able to tell you what each of these is. These are some of the compartments. Then we have the vascular causes: arterial injection, venous extravasation, traumatic vessel injury, especially to the popliteal artery, revascularization and reperfusion, the use of an intra-aortic balloon pump, and phlegmasia cerulea dolens, which is profound distal propagation of an iliofemoral thrombosis, leading to venous gangrene. And this is the only cause where treatment of the compartment syndrome is elevation of the leg. In all other causes, you will tend to keep it neutral at the heart level. This is an example of phlegmasia cerulea dolens. Sometimes it may lead to venous gangrene and can be life-threatening. This is an example of a fracture of the femur, lower end, and you can see a small fragment which is protruding behind like that. That's likely to cause compression of the popliteal artery, and in this patient led to the compartment syndrome. Then you may have soft tissue injuries, direct blow, crush injuries, burns. Then if you have patients who have hypocoagulable states like hemophilia, it increases the risk of a compartment syndrome. And if the person continues to use the limb, it increases the risk. These are the various places it can occur. Pediatrics and young adults are more commonly involved, males more than females. And the consequence it leads to goes by a typical name. And I've put this up for you. Richard V. Folkman. And he has described Folkman's ischemic contracture, which can occur because of the application of tight bandages. And a little more about Folkman. And you can see how Folkman's ischemic contracture looks. So if you miss the diagnosis of a compartment syndrome, you can end up with something like this. And then, after Folkman described it in 1881, in 1906, Hildebrand gave the name Folkman ischemic contracture for results of an untreated compartment syndrome. In 1909, tight bandages, arterial embolus insufficiency, fractures were noted as causes. 1914, Murphy for the first time described fasciotomy. And then, of course, in the 1970s, you had a very accurate method of measuring compartment pressure, which was introduced by Mubarak. The classical clinical features are pain out of proportion to injury, paresthesia and altered sensation, a tense, swollen compartment, the typical description is that pain progresses and the limb is tender to touch. And, of course, if the limb is pale, pulseless and paralyzed, then you've missed the boat. There's nothing that you can do now. So you need to measure the compartment pressure at the right time to be able to diagnose it correctly and give the correct treatment, which is fasciotomy. Difficult to identify who gets tested. So anybody who is suspected, and you need to especially think of it in the intensive care unit when patients are sedated and paralyzed and you've got a swollen limb, because patients are not going to complain of pain and paresthesia, which are the typical early symptoms. Or patients may be on epidural anesthesia, may have had a fracture which is nicely fixed externally, and the limb begins to swell. Because of the epidural, he doesn't get pain, and so you miss the fracture heals, but you're left with an ischemic contracture. This is how compartment pressure is measured. You can see that there's a mercury manometer here. There's a tube, a three-way, a syringe with air, and there is a needle which is here. Now, this simple needle technique can be used with air, or you can inject saline, and it may give inaccuracy up to 2 to 4 millimeters of mercury. But this is one of the methods which has been described. The other, you can see down here, is something which I have not used either of the methods. It's called a digital striker. Striker is the company, and you can see that there's an attached needle which you put into the tissue, and it gives you a digital reading of the compartment pressure. But the gold standard is the Wick method, which was described by Mubarak et al. The tissue pressure is given in millimeters of mercury. Normal pressures are 0 to 8. 20 to 30 results in pain and paresthesia. If you have 30 millimeters for 6 hours or more, it will result in irreversible necrosis. You may get 25 millimeters mercury elevation without signs, sometimes 15 millimeters with signs. So really the spread is quite wide. And Allen et al. Described you wait with 40 millimeters and operate with 50 millimeters. But by and large, the literature describes pressure of more than 30 as significant. Then you may measure a differential pressure, what is called relative compartment pressure. Diastolic pressure minus the compartment pressure. If it's less than 30, perform a fasciotomy. Or you may do what is called mean arterial pressure minus compartment pressure. Again, that is 30. More than 30. Less than 30, then you have to do a fasciotomy. So you do a serial exam. If it's clinically obvious, call surgery. I think if it's clinically equivocal, you should still call surgery. They might say, let's measure the compartment pressure. Do serial compartment pressure measurement. If you find that it's not coming down, then you should have a low threshold for operating and doing a fasciotomy. This is a typical incision fasciotomy, which is shown here. And you can see an example. This is a motorcycle driver who had a fracture, comminuted fracture. The comminuted fracture was fixed externally, and he had epidural anesthesia. The limb began to swell, and patient complained a lot of swelling. Pain was not much because of the epidural anesthesia. And when a fasciotomy was done on both sides, the muscle really bulged out. Fortunately for this patient, the muscle is looking nice and red and viable, and this patient's leg survived. What else can you do? Should you elevate the limb? Like I said, only for a venous thrombosis, you might consider limb elevation. Otherwise, it worsens ischemia. Hyperbaric oxygen therapy, if available, may be tried. Some studies have tried mannitol, but really there is not much evidence. So to summarize, you have to suspect it early. The early versus late clinical findings are having pain on passive stretch and progressive pain, pain out of proportion and palpably tense compartment. Paresthesia and weakness are late signs. You probably missed the boat by then. Do serial observations. If you're not able to get your surgeon to agree, think of doing a compartment pressure measurement. It can be done easily at the bedside. There are no definitive numbers for compartment pressures, but anything, either a difference which is less than 30 or an absolute value which is more than 30, should tell you that this patient probably requires a fasciotomy, which is the definitive treatment. These are some of the references that I've used for making this presentation. But I think I'm out of time, so I will not tell you about the abdominal compartment syndrome, for which I have another 30 slides. And I think you've already had a lecture on this. Thank you very much for your patience.